another session on congenital heart disease. So a review of the fetal circulation. Oxygenated blood comes from the placenta via the umbilical vein and inferior vena cava to the right atrium. The foramen ovale is patent at this time and allows passage of the blood from the right to the left atrium, thereby bypassing the lungs. Blood entering the pulmonary artery from the right ventricle is shunted to the aorta via the ductus arteriosus, as demonstrated here. At birth, both of these shunts close, the FO almost immediately and the ductus arteriosus over the first few hours of life. Congenital heart defects arise from errors in embryogenesis that occur between 3 to 8 weeks of gestation. And causes include idiopathic most often, about 90% of the time. It can also be associated with genetic abnormalities, such as those seen in various trisomies, Creedy-Shott, Turner syndrome, etc. Viral infections, congenital rubella infection, drugs and alcohol, such as that's seen in fetal alcohol syndrome, and metabolic disease, such as diabetes, can lead to increased risk of congenital heart defects. Specific associations, classic associations include atrial septal defects with fetal alcohol, VSDs and Creedy-Shott, trisomy 18 having VSDs, congenital rubella leading to patent ductus arteriosus, and Turner syndrome having classically coarctation of the aorta. There's two categories. There's right to left shunts and left to right shunts in congenital heart disease. With right to left shunts, you have early cyanosis. The blood is essentially bypassing the lungs. The syndromes that are associated with this include tetralogy of Fallot, transposition of the great vessels, truncus arteriosus, tricuspid atresia, and total anomalous pulmonary venous return. Left to right shunt causes late cyanosis, pulmonary hypertension, which ultimately leads to shunt reversal or Eisenmenger syndrome. Included in these syndromes are ventricular septal defects, atrial septal defects, and patent ductus arteriosus. Right to left shunts consists of an abnormal connection which allows the blood, again, to bypass the lungs. Consequently, the blood is not adequately oxygenated, and babies will die if there is no mixing with the pulmonary circulation. Atrial septal defects and patent ductus arteriosus are protective in these patients. Clinically, these patients will have cyanosis, shortness of breath, digital clubbing, and secondary polycythemia. They are at risk for paradoxical emboli because of their right to left shunt. Venous emboli bypass the lungs and get into the systemic circulation. Tetralogy of Fallot is the most common cyanotic congenital heart disease, and it's a constellation of 4 defects. This is the favorite test question of examiners. You have an overriding aorta, you have pulmonary valve stenosis, a VSD, and right ventricular hypertrophy. Blood flow from the right ventricle to the pulmonary circulation is impeded by pulmonary stenosis, so instead it takes the path of least resistance through the VSD and into the overriding aorta. The majority of blood bypasses the lungs, causing hypoxia and cyanosis on exam. Transmission of the great arteries is when the aorta rises from the right ventricle. The pulmonary artery arises from the left ventricle. Blood flow bypasses the lungs, leading to hypoxia and cyanosis. Atrial septal defects, VSDs, and/or PDAs are required to allow the mixing of oxygenated blood. In truncus arteriosus, the septum between the aorta and pulmonary artery fails to form. Mixing of venous and arterial blood causes cyanosis on physical exam. A high pressure output from the left ventricle to the lungs causes pulmonary hypertension and congestive heart failure. Tricuspid atresia is when the tricuspid valve fails to form, leading to right ventricular hypoplasia. Blood from the right atrium flows to the left atrium via an ASD. The left ventricle communicates with the pulmonary artery via a VSD, and you have mixing of venous and arterial blood, which again leads to this classic hypoxic cyanotic syndrome. With total anomalous pulmonary venous return, the pulmonary veins return oxygenated blood to the right atrium instead of the left. Mixing of arterial and venous blood causes hypoxia and cyanosis. The right heart communicates with the left heart via an ASD. Left to right shunts, on the other hand, initially they're left to right because LV creates greater pressures. In severe cases, increased flow from the right heart to the lungs causes pulmonary hypertension. Over time, pulmonary hypertension leads to RV hypertrophy, and this combination leads to a reversal of the shunt. Now the shunt goes right to left, which is otherwise known as Eisenmeyer's syndrome. Blood flow then bypasses the lungs, causing hypoxia and cyanosis, again, late in the disease process, in contrast to the early in disease process associated with right to left shunts. Atrial septal defects, the most common congenital heart disease in adults because most cases are asymptomatic and discovered incidentally, associated with fetal alcohol syndrome. Due to failure of the foramen ovale to close, blood flows from the left atrium to the right atrium. It's usually minor and asymptomatic. If symptomatic, the severity ranges from fatigue to heart failure, and over time can ultimately lead to a reversal of the shunt or Eisenmeyer's. VSDs are the most common congenital heart disease overall. It's associated with various genetic defects such as Credit shunt, partial loss of chromosome 5, Edwards syndrome, or trisomy 18. It's a defect in the interventricular septum, which allows blood to flow from the high-pressure LV to the lower-pressure RV. If it's large, it can lead to tachycardia, failure to thrive in infants, and right heart failure, and ultimately, again, the shunt can reverse and cause Eisenmeyer's. Patent ductus arteriosus. The ductus arteriosus fails to close after birth. Blood flows from the high-pressure aorta to the lower-pressure pulmonary artery. It causes characteristic constant machine-like murmur. If the shunt reverses, it causes differential cyanosis, which means that you'll only see the cyanosis in the lower extremities. Coarctation of the aorta is a congenital narrowing of the aorta. It's more common in males. It can be proximal or distal to the ductus. Common complications include congestive heart failure, intracerebral hemorrhage, and dissecting aortic aneurysm. If you have preductal coarctation, occurring before the ductus arteriosus, these are detected in infancy. Typically, it's associated with Turner syndrome. It presents with heart failure, weak pulses, and cyanosis in the lower extremities. Postductal coarctation presents in older children or adults. There is hypertension in the upper extremities and hypotension in the lower extremities. So on physical exam of a previously healthy 2-year-old, you hear a low-pitched cardiac murmur. Echocardiogram shows presence of the ostium secundum with a 1 centimeter defect. Which of the following abnormalities is most likely to be present? So at this point, this is an example of atrial septal defect that would cause initially a left to right shunt because of the relative differences in pressures in the left heart versus the right heart. Over time, it could ultimately lead to reversal of the shunt right to left and cause Eisenmeyer's, but that would lead to a number of symptoms which, per this vignette, the patient does not suffer